I think it's important to mention that the only reason I've been able to proceed with this work through the years is that when it started many, many years ago, I said, gee, maybe this is not due to the herniated disc. And then I would treat the patient, and they would get better. Mm-hmm. So I had proof that it wasn't the herniated disc. And, of course, that has gone on and on over the years.
Has this made you perhaps a little bit unpopular? Because you work in a hospital, really makes its livelihood from the modalities that they offer.
Well,
and you're a voice basically saying, don't bother with that because that's not really where it's at.
First of all, nobody really feels threatened by me. Let me tell you one of the interesting and very, very sad facts as to why they don't feel threatened. Although I think this is extremely common, I won't say it's universal. 90%, 85 to 90% of the people who have one of these things will not accept my explanation.
Okay.
So what does that mean? It means doctors have to continue doing what they're doing.
So there will always be business for doctors.
Yes. Exactly.
No matter, you do not threaten the medical paradigm. You can help if you select people who are open to your message,
exactly,
and who can do the type of change work that's necessary to overcome their pain.
That's right.
So this is not for everyone. It's kind of like, how many Dr. Sarnos does it take to change a pain patient? And the answer is only if they're willing.
I have to tell you something that's very interesting in that regard. There's a doctor in Arkansas who came to see me many years ago. He's an orthopedic surgeon. And he tried to treat people with pain, and he was never successful. And then he read my books and so on. And he came to see me and spent some time with him. He went back to practice in Arkansas, and he says, whenever he makes the diagnosis, he tells the patient what he thinks, and if the patient accepts the diagnosis, he treats him for the TMS. And if the patient doesn't, he said, I treat him the way he wants to be treated.
I can understand that because, what are you going to do? If the patient doesn't accept that is a pathway, you do the next best thing, which is to do surgery or give them medication or relieve their pain in the best way possible because they're not open to this more comprehensive treatment modality. So when we return, Dr. Sarno, I want you to develop the theory of TMS because TMS is
good. I think I should. That's right. People should know exactly what we mean by this and what happens in the body.
All right, we're gonna review the syndrome that is responsible not just for back pain, but for a vast array of pain problems, including fibromyalgia, carpal tunnel syndrome, and many bodily afflictions. Our guest is Dr. John Sarno. He's author of a dynamite book that you should get called The Divided Mind. I'm Dr. Ronald Hoffman, and this is Health Talk. Back to Health Talk. I'm Dr. Ronald Hoffman. We're talking to Dr. John Sarno, one of the most celebrated but one of the most controversial figures in the field of medicine because he challenges the current medical orthodoxy that bases its treatments on suppressive drugs and surgery, especially to treat pain problems. He's got a comprehensive theory that describes how the mind can actually cause physical changes in the body that lead to chronic pain syndromes. The theory is about TMS. Could you explain it? Not PMS, but T.
T as in Thomas.
Right.
Yeah, T stands for tension. I gave it this name years ago, and the tension I meant to refer to the psychological things. The M, and now this is controversial. As a matter of fact, I have to tell you something interesting. Even in The Divided Mind, that last book, I called it myositis, which means something happening to the muscle. Myo is muscle. Because when I started this work many years ago, I thought that muscle was the only tissue involved. It turns out now that we find that nerve structures, spinal nerves are probably the most common, are much, much more commonly involved. So very recently I decided we should call this the myoneural, tension myoneural syndrome. And syndrome, of course, is the term that applies to anything in medicine. It has many, many manifestations.
So you say in the book that you can actually measure changes in blood circulation and oxygen levels in tissues that are affected by this.
Oh, no. I can't do the measurements. Actually, certain studies have been done in the medical literature in which they did do the measurements.
Okay, but you're not doing it. You don't have a meter that you can do this.
No, I don't have a meter. But what I assume is based on the symptoms I'm finding, both what the patient complains of and what I find on physical examination, it tells me which spinal nerves, and I'm using that because that's far and away the commonest manifestation now, which spinal nerves are involved. Now, here's what happens. As these spinal nerves peel off the spinal cord, let's say in the low back, as they get out into the soft tissues, that's where I think the brain will reduce the blood flow just a little bit. Not enough to really damage the nerves, but certainly enough to cause dysfunction. And that reduction in blood flow means a mild oxygen deprivation. So in other words, we're seeing symptoms as a result of mild oxygen deprivation to spinal nerves. And that's why the pain may be in the low back, it may be in the leg, because these spinal nerves are all going into the leg, and then we've got a set up in the neck that are going into the arms and hands.
Now, I'm going to be the devil's advocate here, because the psychiatrist would say, great, we believe that stress is a big factor in disease, and what we just need to do is identify these patients. Many of them, they're depressed, they have anxiety. Let's give them Prozac, Zoloft, Ativan, Klonopin, medications that will calm their mind, and their pain will go away. What's wrong with that approach?
Couldn't be anything more wrong, because in fact, depression and anxiety themselves are the result of these unconscious phenomena that are going on. When you give patients, well, certainly if you try to do that, and doctors have done this over the years, they've tried these drugs on patients with pain problems.
And in fact, many patients they're on 5 or 6 different drugs.
Oh, sure. No, actually, the problem is that the drugs, if we're talking about depression, we'll certainly deal with the depression, but that's just changing the chemistry. The depression itself appears to me to be due to the same underlying unconscious things that are causing the pain. I call depression and the pain of these things sister and brother. I call them equivalents of each other. And I've seen this in patients. You
actually have accounts where in getting rid of the pain for some patients, they develop tremendous anxiety and depression.
Exactly.
Because you use a great term in the book. I've really picked up on this. It's called the symptom imperative. Can you explain what that is?
I'm glad you did. You see, when the brain decides for our protection, and I have to keep repeating that, for our protection, that some sort of symptom is necessary, if you take that symptom away in a way that's specious, that doesn't really deal with the underlying problem, the brain will simply give you something else. And I see that all the time. And that's why we call it the brain will not be denied. Unless you deal with these things properly and appropriately, the brain will simply give you something else.
Well, this is a real fundamental challenge to our current medical paradigm, because what we do is we look at specific conditions, and if you have one problem, you go to one doctor. The doctor fixes the problem. And you might have an operation for, say, carpal tunnel syndrome or hip pain, a knee replacement, back surgery, and then you might manifest with another problem. You might develop gastroesophageal reflux. You go to the gastroenterologist. He'll give you an acid blocker, and on and on and on. You could have a whole lifetime portfolio of medical ailments.
Let me say this, that when these other things occur, and I'm glad you mentioned the gastrointestinal things, it is appropriate for a doctor to treat them with medications, but what they don't do in addition is to say, but it's important for you to understand why you got this, what it means in your life, in your psychology. And that we don't see, unfortunately.
Well, where does it stop, though? Because at some point people are going to say, look, Americans eat a lot of junk, they're overweight, they don't exercise. Surely these are factors that contribute to pain and discomfort.
Yeah, well, of course, there's no question about it. And the thing that I complain about, and as you probably know from the book, there are no studies done that consider the emotional factors as one of the risk factors. Sure. You're talking about cardiovascular disorders. There's no question that diet, exercise, cholesterol, and all of those things are important. But you don't have the NIH studying the possible effect of powerful emotions. And that's what I say is lacking, grossly lacking in American medicine.
And maybe because there's no modality that handles that, there's no payoff, there's no cure available.
Well, yeah, that is one of the problems, of course, with the pain. Pain treatment has become a major industry in the United States. And, of course, there isn't much impetus to try and look further into the problem.
You actually say in the book that certain ways of treating pain, showing a patient an X-ray and saying, look, this is where your pain is coming from, or giving patients, say, special orthotic supports in their feet, may reinforce the pain, make the pain worse. How does that happen?
Well, sure, because the patient says, well, I've got this structural abnormality. And, yeah, we're going to try to do something about the structural abnormality, but the pain continues. In fact, one of the jobs that I have to do with some patients is to say to them, now, look, we're in an entirely different ballgame here now. Your herniation, your herniated disc is not causing the pain. You've got to stop thinking about that. You've got to forget what your MRI shows and listen to what I'm telling you about what is really going on in your body.
A lot of patients become virtual cripples. They avoid certain exercises, they take to bed, all of which doesn't help.
Oh, yeah. This is what's so sad about the whole thing.
Actually, you point out a study, very interesting study, that looks at two adjacent countries. One, I think they were in Scandinavia, and one was the former socialist country.
It is Norway and the Lithuanian.
Norway and Lithuania, where they had one country had elaborate legislation that helped people get insurance compensation for whiplash. Right. The other country, they couldn't care less because there was no government support or insurance support for it. What was the difference in the statistics?
There was no incidence of whiplash in Lithuania. And in Norway, it was epidemic. That's what made these doctors travel over to Lithuania to say, gee whiz, maybe it's because we have this easy availability of good treatment that's helping to spur this thing.
We're in effect reinforcing disease by creating categories, names we now show on TV, new ailments that people can identify with.
Yeah, exactly.
We teach people to desire knee replacements, hip replacements, and maybe this is driving the pain industry.
Well, there's no question about it.
All right. When we come back, we'll talk about what the actual process might be to address a complex pain problem, the kind of thing that Dr. John Sarno does on a daily basis and has for decades with thousands of patients that he's treated for various pain syndromes. His latest book, The Divided Mind, lays it out. I'm Dr. Ronald Hoffman, and this is Health Talk. Back to Health Talk. I'm Dr. Ronald Hoffman. We're with the fascinating, always controversial Dr. John Sarno. He's written a new book called The Divided Mind. It's his most ambitious book so far because it tackles not just back pain, which he's famous for treating. He's relieved the back pain of literally thousands of patients with his methods. Now he's extending it to all manner of mind-body disorders. And what are some of the conditions that are amenable to this approach besides back pain?
Yeah, and you say amenable, it really works because I've had patients who come to me for the back pain and then they've had other problems. For example, a physician I saw not too terribly long ago was having terrible problems with allergies every springtime. And I told him when I saw him, now, we're going to work on this, and what I want you to do is to put that allergic thing into the same bag with your back pain. And the next spring he had nothing. So common allergies fall into this category. Common gastrointestinal things, the stomach, the irritable bowel syndrome. Common skin reactions, headaches of various kinds. Now, you understand, I expect all of my patients to be thoroughly studied before I see them.
Right, because God forbid you might. I mean, there are organic problems. You can't say, well, I'm going to cure an obstructive colon cancer.
Yeah, it would be irresponsible of me to take them on and say, oh, your headache is nothing, and it turns out to have a brain tumor.
Right.
So, but these are common things Urinary tract problems, for example.
Like urinary frequency, unexplained origin.
Extremely common, exactly. And so it became clear over the years that these things are all reacting to the same psychology. All right, you said, how do we treat them?
Yeah, like what is it like, nuts and bolts? Somebody comes to see you,
all right.
They sit down, present their case. What do they have to do?
All right, I examine them, and in that first session, I have to have a prolonged session with them at the beginning.